Good evening, everyone. Good afternoon, everyone, as well. I'm here on the West Coast. And thank you for joining us on World AIDS Day. This is a global movement to unite in the fight against HIV, but it's also a day to honor those we've lost, celebrate progress, and recommit to justice, healing, and equity. The purpose of this BDO Live is simple: to speak honestly about the disproportionate impact of HIV in Black and Brown communities, and to create a space for dialogue on prevention, testing, and treatment. We thank blackdoctor.org for making this conversation possible. This year's theme for World AIDS Day is overcoming disruption and transforming the AIDS response. This is especially meaningful because the numbers tell the story. Nationally, about 1.2 million people are living with HIV, with 38,000 new infections each year. And although Black and Latinx populations make up about 30% of the US population, in 2022, we accounted for 70% of all new infections. These numbers make one thing clear: HIV remains a crisis of inequity, touching our families, our neighborhoods, and our communities the hardest. That's why today's theme isn't just a slogan, it's a call to action. Thank you for being here, and let's carry that spirit forward in our conversation today. First, let's take a moment of silence to honor and remember the millions of lives globally lost to HIV and AIDS, and reflect on the love, strength, and resilience that they shared with the world. Thank you. In the interest of time, we'll provide abbreviated versions of our panelists' biographies. These are wonderful panelists we have assembled today. We'll still want to honor their experience and contributions. However, when we first start to introduce one another, if you can just briefly tell everybody who we are, so everybody knows that we're family and what kind of work that we do. The first person I'm going to call to talk with us will be Dr. Spencer. Dr. Spencer, from your discipline's perspective, what HIV prevention strategies are proving most effective in Black and Latinx populations?
Hi, everyone. It's good to be with you today. I'm LaShonda Spencer. I'm the director of Drew Cares, which is the Center for HIV Services here on the Charles Drew University campus, and also the clinic lead for the Oasis Clinic at Martin Luther King Outpatient Center in South LA. Thank you for having me, and so good to be here with you. In terms of the prevention strategies for Black and Brown communities, which is the community that I serve, if we talk about from a systems and provider level sort of look, really prevention starts with understanding the community that we're serving and being able to provide culturally tailored education and services, really understanding the beliefs and values and practices of the communities that we serve. It also includes involving community members and leaders in your activities in terms of your services that you're providing around prevention, as well as in implementing these programs. It includes improving access to our services by our systems of healthcare, which sometimes leaves communities of Black and Brown individuals out. It also includes providing comprehensive multidisciplinary services that really address the barriers that some of our community members experience as they're trying to access the care. So providing transportation services, having cost-effective and programming that helps patients pay for services, as well as availability of time. Many of our community members work, long hours, and so having evening clinics and availability on the weekends is really helpful. The campaigns that we use in terms of understanding systems issues as related to prevention are really important. Campaigns around education need to look like our communities we're trying to If you don't know, if you're looking at the TV commercials, the ads in your lobby, the ads on the billboards, if they don't look like the individuals we're trying to serve, then the message may not apply to me, as I'm thinking from a community level. And then in terms of on the individual level, really prevention starts with knowing your HIV status and the status of your sexual partners. And I think that's really important to understand that from the individual level, as well as for the provider to be able to be comfortable enough with taking sexual history, where they understand that testing really is the way to talk about prevention, whether it's prevention for HIV or prevention for other STIs, including using DoxyPEP.
You mentioned DoxyPEP. Can you explain a little bit more to our audience what is DoxyPEP?
Sure. DoxyPEP, or doxycycline post-exposure prophylaxis, is using doxycycline, which is an antibiotic that we've used for many, many years, safe and effective for skin and soft tissue infections and acne and other things that we used it for. But it is used to prevent STIs, particularly chlamydia, gonorrhea, and syphilis. Individuals will take DoxyPEP, so it's post-exposure, so actual after a sexual encounter, but within 72 hours of a sexual encounter, ideally within 24, and you take 2 tablets, and that's it, one altogether on the same day. It has really effective against preventing syphilis and chlamydia, which we really do have a huge epidemic with chlamydia infections, including leading to, syphilis infections, including more congenital syphilis because of the high rates of syphilis we have in the communities, particularly brown and Black individuals. So DoxyPEP was instituted to help curb some of the syphilis epidemic that we're having, and it's been shown to be effective.
Great. Thank you very much. And so this is something a primary care doctor can do then?
Primary care doctors can do this, family med, OB. Let's not forget about women. We frequently are left out of the conversation when we talk about PrEP, and even PEP and DoxyPEP.
Okay. All right. I forgot to introduce myself. My name is William King. I'm an internal medicine doctor. I'm so excited to be with you guys. Forgot to introduce myself. I'm an HIV specialist in private practice in Los Angeles, in the Crenshaw area. I'm also clinical associate professor, actually assistant professor now, over at Junior University. Now, one other thing, Dr. Spencer, you mentioned PrEP. What is PrEP? I'm hearing that we have various options now for our patients.
Yeah, this is really an exciting time. PrEP is pre-exposure prophylaxis for HIV prevention. We have choices both orally and injectable, 4 choices to choose from. So 2 oral and 2 injectable. All of the PrEP options are highly effective if they are taken as directed. And so that's the challenge, particularly with oral medications, is taking them as directed. Remember to take them whether you're taking it daily or if you're taking it as a 2-in-1 or event-driven medication. They only work as if you take the pills. For the injections are given in the doctor's office. So the injections are given either every 2 months with cabotegravir or every 6 months, the newest kid on the block, with some or lenacapavir. That's an injection given every 6 months. So there are different options for different individuals. The efficacy is very good if you take them. The injectables were proven to be superior to the orals because we can give them in the office and patients come to their appointments to get them. But oral pills are highly effective as well in terms of prevention of HIV infection. So lots of opportunities for prevention for those that may have a vulnerability to HIV. We have options for you. And the key is really understanding what your options are, what works for your lifestyle. Because if you've got a busy lifestyle and you can't come to the doctor's office every 2 months for an injection, or you travel a lot, or for whatever reason, even every 6 months is difficult, then maybe having a pill at home is easier for you. But if having a pill at home means that someone may find out that you're taking the medication, you're concerned about stigma around the medication, or you just forget taking pills daily, then the injection may be for you. So these options are ones that you discuss with your provider to see what best fits your lifestyle, because there's something for everyone at this point.
Excellent. Very good. The main thing what I'm hearing now is that patients have choices.
Many choices. Yep.
So if someone gets tested, they know their status. If they are testing negative, we can provide them the option of PrEP. What about if they test positive? And the questions that we're hearing, maybe Ms. Diggs could help us with this, and please introduce yourself as well. What concerns or misconceptions you're hearing about HIV that's most frequently among the Black and Brown communities as well? We heard the numbers that we're small in the population, but we're big in terms of the numbers of individuals living with HIV. But what have you heard with regards to Black and Brown patients, families, youth, and faith communities? And how can we address these misconceptions, if we will, with culturally grounded, accurate information?
Thank you so much, Dr. King. Hello, everyone. It's so great to be here. I am Alicia Diggs. I am the manager for the Office of Community Engagement at the UNC CFAR Center for AIDS Research. I'm also a woman thriving and living strong with HIV for over 2 decades now. So to your question, so one of the biggest misconceptions I continue to hear as a person who works with the community, especially the Black and Latin communities, is the belief that HIV is still a death sentence, or that people living with HIV are dangerous, promiscuous, or somehow responsible for a diagnosis. There's also a deep fear. This is what I hear from the community, a deep fear around disclosure, judgment from family members, especially the faith-based organizations if they are connected to such. And there's also confusion about treatment, particularly around U equals U, which is the truth that a person living with HIV who is on effective treatment and has an undetectable viral load cannot transmit HIV.
Wait. Say that again, please.
Absolutely. U equals U, which is when a person living with HIV who is on effective treatment and has an undetectable viral load cannot transmit HIV.
Okay.
So that message is very life-changing, but so many people in our community still have never heard about it. And then another is also the mistrust of our healthcare system. Fear of being mistreated or talked down to, and lingering myths like you can get HIV from sharing food, toilet seats, and from being in the same room as someone living with HIV. I literally just had a session that I did, and that was some of the responses that I received from people who are really not that much connected or understand HIV. But those misconceptions, they come from years of stigma, silence, lack of accessible education. But when we address the barriers by not just meeting people where they are, but where they want to be met culturally, spiritually, and emotionally, that means sharing information and language that and context that feel familiar and safe. It means bringing U equals U into churches, barbershops, community centers, youth spaces, and also using stories and not just statistics. Because when people hear someone like me, a Black woman living strong and healthy and leading with HIV over 2 decades, they see possibility instead of fear.
Mm-hmm. I like that. I like that. You mentioned the faith-based organizations and partnerships as well. I think, why don't we bring Reverend, I'm so sorry, Reverend Gibbs in. Sorry with my eyes there. Reverend Gibbs, tell us a little bit about how do we incorporate faith-based partnerships within the Black and Brown community? We're still hearing about stigma, we're still hearing about silence, but how can we have community organizations and faith-based organizations help us?
Thank you, Dr. King. Thank you for inviting me, and thank you for allowing me to participate in this panel. My name is Jimmy Gibbs, and I live in the rural South. And not only am I a clinician by training, I'm a faith leader and a member of the United Church of Christ. I have partnered with many folks over the years. My foray or my introduction into HIV came at Duke University. When our patients were being discharged, there was no aftercare. So the aftercare pretty much was on the community. And we had a couple of doctors at that time. We talked about Dr. John Bartlett and some others at Duke who founded an organization that I've been a part of since the beginning called ACRA. At that time, we were the AIDS Community Residents Association. And at that time, when they were released from care at Duke or UNC, which are our primary institutions that they would be, that they would be discharged from, we provided housing in 1987 to provide them with that safe space for healing, recuperation, so that they could get back on their feet. And the stigma is real. We had families, even in the 80s and 90s, that would drop their loved ones off in our parking lot or in the front yard. The only way we knew they were there was we had a light that would come on and let us know that someone was needing our assistance. This happened in the 80s, and it still continued until yes.
I'm so sorry. Can you repeat that again? A light came on where?
So we had the lights on. We basically bought a house on the outskirts of Durham County, way out in the county, but it was on the Eno River. It provides solace for our folk. And it was healing through being in community with others like us. And we provided that care as a 24-hour care facility that opened up in 88. And we provided that care until the 90s. We were granted a HUD 501c, HUD 811. HUD provided that those resources for folks to take care of folks who were disabled and folks living with HIV. So we were able to get in there and start this housing program that evolved into attaching ourselves with all of the major healthcare systems in our area, Duke University, UNC, and Wake Med. And they provided a lot of the infrastructure for our folks to be able to ride vans for treatment. They were able to connect and link them to care, whether it was doctors, whether it was a nutritionist, whether it was just a place for them to talk. So those resources were in place even in the 80s and 90s. And those resources are still available today. And I'm just proud of that organization that has been around, for almost 4 decades now.
Amazing work. I mean, when we talked about some of the things that Dr. Spencer opened up with, the need for having partnerships, transportation, commercial support, all the keys for success, it sounds like you were doing this way back when. Fantastic work as well. Dr. Tan, I'm going to come to you real quickly, if you can, please. So I'm hearing that people, as Dr. Spencer said, people are thriving. And also, as Ms. Nix said, people are living longer lives as well, too. It's not the death sentence that we first heard about years ago when many of us started HIV or hearing about HIV. But people are living longer. I'm also hearing that now that more than 50% of the people living with HIV are 50 years plus, right? So there are not only the situations of living with HIV, but also when we're dealing with individuals 60 plus, we're dealing with geriatric concerns as well in terms of healthcare. How do we keep people with HIV who are seasoned, for lack of a better term? How do we help them stay healthy and active as they age? How do we support them? What type of healthcare concerns should we address with individuals living with HIV who are 50 plus, 60 plus, et cetera?
Thank you, Dr. King. It's a pleasure to be here. I'm Judy Tan. I'm a professor at Cedars-Sinai, and I have been doing research with communities of color living with HIV, impacted by HIV throughout the country, throughout the United States, more recently in California, in Northern and Southern California. You're absolutely right. More and more of us are living and thriving and living longer with HIV, and certainly aging is not an appropriate word to describe some of what's happening. I will just say that there's a chronological age, and then there's a sort of a biological age, if you will, where prematurely what we had been seeing in people who are relatively young, living with HIV, relatively young, but demonstrating symptoms, aging symptoms that we typically associate with much older age. Typically, they start happening in late 40s, 50s in people living with HIV. And that's why the benchmark age for people living with HIV is 50, although 50 is certainly not old as someone speaking, as someone who is nearing that age. And so some of the main issues really came from what community told us as researchers. So doing this work and doing this work correctly, as Dr. Spencer, as Ms. Diggs, and as Reverend Gibbs have mentioned, doing this work with communities of color means engaging in collaboration and co-creating interventions with communities of color impacted by HIV. And what the communities have told us is that the existing interventions and programs don't necessarily serve people already living with HIV. They've been there and they've done that, meaning that they know how to take their meds. They're well engaged in care. By the time that they're living longer with HIV, they're well engaged in care for the most part, right? And much of the programming available for them, and I'm talking about 5, 6, 7, 8 years ago, when all of a sudden, ID docs are seeing, physicians are seeing their patients who are living longer. Some of these programs are not addressing the golden years of living and thriving with HIV. And let alone, among women, among trans women, among cis men, let alone that, right? We're talking about a wide swath of people who are older and living with HIV. So I developed an intervention to address some of the most common issues, which are loneliness and social isolation. So what the literature showed and what community had told us is that programs are not suitable. Existing programs, social programs, I should say, social support programs are not geared towards supporting people in their golden years. 2 is that their chosen family may have their the social circles are shrinking, meaning that as people get older, friends and family pass away and chosen family pass away, and for some folks, rejection from family still happens. And so the social support aspect is ever so important. And so United Voices was created. It's a group singing intervention that was co-created with lots of community engagement in Oakland, California, where and we had a choice between San Francisco and Oakland, and we went with Oakland because of the need and because of the unaddressed, relatively unaddressed epidemic in Oakland relative to SF. And what ended up happening was spiritual leaders and choir directors got involved and created United Voices. And then the pandemic hit. And imagine, an intervention, bring people together to sing gospel music. And then the pandemic hit, and we could not bring immunocompromised folks in the same room singing and breathing and during COVID. And so social isolation happened. And long story short, we were still able to do the research. And one of the links is the links to the final concert is a YouTube link that's available in the chat if folks are interested.
Fantastic. I hope that everybody that's at home is able to tackle that as well too. That's exciting. Can you help us understand a little bit, what is the difference between loneliness and social isolation? To me, it sounds the same, but what is the difference?
Yeah, the easiest way I like to think about it is one can be lonely in a room full of people. And these loneliness and social isolation are related concepts, related certainly experiences, but they are different in the sense that one can feel lonely and one can be socially isolated like we were during COVID. During COVID, we were socially isolated, physically distanced, right? And so social isolation has to do with physical distancing, influencing one's ability and access to social support. Loneliness is related but can be independent of social isolation. I can be socially isolated. I can be physically distanced, but socially connected. What are we all doing right now? We're physically distanced, but we're socially connected. And so we really leveraged that very, very, very much during the pandemic to make United Voices happen. So everyone sung in their own homes and then recorded themselves, and we were able to stitch people together, bring people together on Zoom to sing weekly. And then they got to know each other and they supported each other. And then they produced this beautiful concert at the end of all of this, all while physically separated.
Fantastic. Thank you. What a wonderful project. I'm very interested in it. Does anybody else in the panels have anything else to contribute with regards to this growing topic that we're seeing about how do we were years ago, we were just focused on the issue of keeping people alive. Now we want people to thrive and all the other things that can happen in terms of social isolation, transportation, housing. How else do we help our patients? What else do we do?
So I wanted to add to what Dr. Tan was speaking of when we talk about HIV and aging. One group that we don't talk about nearly enough when we talk about HIV and aging is our lifetime survivors. Those are persons who were born with HIV or diagnosed at a very young age as children. These individuals have lived with HIV for decades. Some of them are 30, 40 plus years old, and their experiences are profoundly different from those of us diagnosed later in life. I am aging with HIV, being a person that's 50 plus, still young, but still aging. But when I think about our lifetime survivors, they've navigated childhood, adolescence, adulthood while managing treatment, stigma, disclosure, and questions about their own identity and future. Many of them even survived the eras of toxic medications, harsh side effects, constant uncertainty. And they, like I mentioned, are 30s, 40s, 50s with unique medical and emotional social needs. I mean, I can go on, but they are, like I said, often left out of the conversation because people assume aging with HIV only applies to long-term survivors from the early epidemic. But these individuals are long-term survivors as well. They deserve to be centered, supported, and acknowledged for their resilience and for the fact that they never knew a life without HIV.
Thank you, Ms. Diggs. And you talked about the issue of populations that we often don't talk about as well, too. Dr. Spencer, can you talk a little bit about, are there like gender differences that we see with individuals living with HIV versus those individuals who have a reason to be on PrEP? Like, are we seeing differences with regard? We're talking so much about the numbers. We talked about the racial disparities, but there are also gender disparities with regards to access to care and also to HIV treatment.
Yeah, certainly. I think that because the epidemic has been concentrated in the male population, and different expressions and gender identities around male populations, we tend to forget about the woman that's living with HIV or that may be vulnerable to HIV. And so she doesn't get the message that maybe she should be tested, maybe she should be offered PrEP, because the messages out there that we see in the community does not look like her, does not say anything about her. And so it's going to be up to the provider and for us and these webinars like we're doing today to really educate that anyone that's having sex should be offered PrEP, should be educated on PrEP, and get an HIV test. That's so important that we do that. Younger populations, we tend to again focus and mostly on the young gay male in terms of HIV testing. But as a woman specialist who does a lot of PrEP in women and a lot of HIV care in women, you know, there are a lot of women who said, if I would have known, had someone told me, had someone offered me, you know, and so we got to think about that for sure. And I also have taken care of all of a lot of lifetime survivors, as Alicia has mentioned as well. I'm now taking care of several generations where grandma, mom, and now baby, younger baby, of several young women who are now having their own babies. And so it's really just, for me, very fulfilling to take care of generations of folks that are either living with HIV or have been affected by it. And there are differences in terms of, you know, how you grow up. If you are a lifetime survivor of HIV versus someone who got HIV when in their older adult or even older adolescent age range, and now you've lived with it for some time. There are significant differences. We talk about some of the cognitive differences that we see if you've been living with HIV for a long period of time. A lot of the early studies we did in pediatrics and in adolescents in terms of those kids that were born with HIV or those who've been exposed to HIV for such a long period of time in terms of during their pregnancies and whatnot. And so those important differences are continuing to be hashed out in terms of what are the effects of a long time exposure to HIV. If your body has never lived without HIV because you were born with it, that's so much different than if you acquired HIV at an older age. And we're still looking at some of these differences. We talk about accelerated aging, and Dr. Tan talked a little bit about that in terms of, you know, your biological age versus your chronological age. And we know that HIV creates a sort of an accelerated aging process in individuals. For women, that may mean that menopause starts earlier. So we have to be more concerns about osteoporosis. Cardiovascular disease is about the same in both men and women in terms of outcomes. However, for both groups, it is a little bit accelerated, but no gender differences in that. So there's lots of things that we're still learning about in terms of how living with HIV for such a long period of time affects our bodies. And you were right. It's been mentioned several times that in the beginning, when I first got into HIV care about 25 years ago, we were really just fighting those opportunistic infections, just trying to get folks, help people tolerate the medications, die with dignity. I mean, it was just such a different story than it is, you know, for the last 10, 15 years now, and helping people thrive and live healthy. It's more than just taking a pill every day. It's about your whole physical, mental, spiritual well-being as you're living with HIV, and really trying to change folks' mindsets who live those early days and still just remember the trauma of those early days. And how do you address that from a mental health point of view as well? Because we can't say, oh, just take a pill and, you know, it's look, you've been living all this life. That's not the right answer to do this. We have to address the entire being of individuals. So it definitely has changed the way we practice medicine, especially me. I'm an infectious disease doc. Thought all I was going to be doing really was just treating the infections, and that was it. But now I've become a primary care provider right, of my patients, and they're living long, healthy, just thriving. I love it. Love the work that I do.
Fantastic, fantastic. And then along those lines, Dr. Tan, I also imagine as people are aging, both chronologically and biologically, one of the concerns we may have is polymedicine, polypharmacy, right? For me, because it's not just HIV and controlling getting people undetectable. We're concerned about diabetes, the cholesterol. Dr. Spitzer mentioned osteoporosis, et cetera. How do we talk to our patients about this polypharmacy? If they're going to a cardiologist, they're going to an HIV specialist, they're going to an OB-GYN, how do we get them all to work together, or do they work together?
Well, I thank you, Dr. King, for that question. I will definitely defer to you and Dr. Spencer and others on this panel to answer more specifically about polypharmacy, but certainly part of my work with Golden Compass, which provided pilot data for United Voices. Golden Compass was a comprehensive wraparound service for older people living with HIV out of Ward 86 at SF General, San Francisco General Hospital. And and one of the main issues was polypharmacy and how do you talk to patients and how do you address contraindications? How do you take into consideration all those things? It's an art and a science, and I have the highest respect for the physicians who see patients with those with additional things, because HIV, as I had come to learn in working with folks living with HIV, is that it is relatively well managed relative to other new things, new illnesses and diseases, things like cancer and things like diabetes, cardiovascular issues, even cognitive function. So those are things that for which that people take medicine, and that's often something that I in interviewing and talking with physicians who are part of Golden Compass. That is definitely something that they're keyed in on. So.
Fantastic. I want to also hear from Ms. Diggs and also Reverend Gibbs, but before we do, are there any wants to welcome the audience to make sure that they are participating as well? Do they have any questions? Please put the questions in the chat. Right now, do we know if there are any questions from the audience? Okay, well, we're looking to see if there are any questions from the audience. Reverend Gibbs, what is your take on this matter as well? Because there's a lot to do now.
And you're so right, Dr. King. I remember I am a person of historical means. I'm an old soul, but I remember what brought community together in the 80s was the original AIDS care teams. We formed AIDS care teams all over the country using the community. So we would challenge or ask, is there anybody or any church or any related organization that could provide assistance for as part of an AIDS care team? And those care teams have been around. We have some AIDS care teams that have been around for 30 plus years now in the Triangle area. And they are still raising money. They are still knitted together, and they oversee the spiritual, the emotional, the journey that people have as being a part of the community. So those AIDS care teams would come right over to our homes, right to their homes, see what they needed, blankets, if they needed food, if they just needed someone to talk to. And we have 5 still out of the original 60 still servicing. And that's pretty good because, like you said, we have people that are on the spectrum of care. And as you get older, I remember someone needed a cane. Well, somebody showed up with 18 canes. So, those kinds of things are just like family, community. And I remember those. And you're talking about faith. Okay. I remember working with Dr. Pam Foster about ministers introducing them to the stigma and what HIV was. So Dr. Pam Foster did a program that 20 some years later was followed up at Duke University by Dr. Sadie Wilson. So Dr. Pamela Foster passed the torch to the younger generation, Dr. Sadie Wilson at Duke. And we even looked at, has stigma changed from the time that she did the original study with faith leaders to now? Stigma is pretty much, we haven't published yet, but those findings are going to impact the way we do business today, how we treat people, how we engage the community. Because the same stigma that faith leaders had then, they have now. No, we can't do that in our church. No, are there other organizations that can do this work? We really don't want the taboo of having you in our sanctuary. Oh, you can meet here. We've heard a lot of different ways to engage community, but the faith leaders are still on the fence about how to do it within their own churches and faith communities. So we're still tackling that some 25 years later. And I just know that there's an answer. Don't know what the right answer is, but we're still in the fight to, make sure that people know, like you equals you, like Alicia said, we've got to continue this journey and work together as faith leaders, researchers, clinicians, to see that we can bring everyone to the table. I used to have a saying, if you're not at the table, you're on the table. Right. And Alicia had a better one than that one. What was the one that you had, Alicia?
It's actually from Wahida Shabazz L out of Philadelphia. If you're not at the table, you're on the menu.
That's pretty good for her. But I think that we still have to be in that race. And the race for me, I still feel energized, even in my 60s now. I still feel energized about the work that we began in the 80s. I'm not letting go until it's time for me to go. So I'm still in it to win it.
Excellent. Fantastic. Are there things that when you are met with spiritual leaders, because spiritual leaders, faith is so prominent in Black and brown communities, what happens when you meet someone that's quoting scripture to you about the work of the work, and it challenges the work that you do? So you start hitting the Leviticus on you, etc.
It weighs heavy on me. In Christianity, we're taught that even though there will always be poor among us, that was Jesus's challenge to the folks of that time. What do we do because they're poor among us? We take care of them. Just because they're poor doesn't mean that we have to forget the responsibility that Jesus said to take care of everyone. Mm-hmm. So that challenge to us, challenge to that community years ago was, well, Jesus said there's always going to be poor among us. So what should we do? Continue to work together, continue to do good, continue to work together as a community so that you can eliminate hunger, so that you can eliminate stigma, so that you can eliminate all these barriers that really get in our way of doing the work that I think the Creator has us to do, which is to live in community with each other. Not live in hate, but live in peace, live in community, and try to help each other. Like a community garden, we all have to contribute to the community garden, whether we weed in it, whether we water it, or whether we take from it and share what we get with others. So I still think there's a lot of work to do with our faith leaders out here. And we don't have enough faith leaders talking about this. They consider me, oh, well, Reverend Gibbs is the HIV expert, and I'm like, no, all of us need to be on the same level and learning curve as I am. So we have to impart that knowledge as community resource people, as experts, as subject matter experts, to make sure that people have the same information that we do as clinicians and ministers.
Fantastic. Thank you so much. I know I'm sorry, I'm echoing there. I know we're getting close to the hour, so there's so much more to learn from everybody that's here at the table. I do want to hear from everybody about this. How do we engage the community more with regards to this? We started it with this number by saying the high percentage and the disproportionate percentage of Black and brown individuals of the number of individuals are newly diagnosed. What do we say to an individual who's newly diagnosed? How do we make sure that we're escorting them to appropriate care they feel comfortable and dealing with all the issues of stigma, all the issues of mistrust? And how do we court someone who is at reason for being on PrEP? How do we get them to the proper channels? What do you do when you meet individuals that make that situation, either newly diagnosed or someone that wants to be on PrEP? And that's open for everybody.
I can start. I think for the newly diagnosed, really, it's a hard diagnosis to get, especially if all you know is about what you thought you knew and what the stigma and stereotypes are out there or what you grew up with. So it can be a shocking diagnosis. And so sometimes just taking the moment to just do a little bit of education, and also knowing that when I see a new client, and I explain this to them at, at probably their first 3 or 4 visits, I'm going to talk to you about a lot of things in terms of education and trying to re-educate you on HIV and how well you can live with this illness. But they're only going to get probably about 10 seconds of what I've said.
Mhm.
Right. And I realize that. And so I say that, you're not going to remember anything that I've said after this. I just want you to know I'm going to take the best care of you. You can live a long, healthy life with this illness. And then I'll go over some of the education, and then I'll do the same thing the next visit. I know you're not going to remember anything that I've said, but let's just review some of the things we talked about. And I keep doing that until they say, okay, Dr. Spencer, I know, I blah, 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 I can do, and they can give the lecture that I give. And so I think that really is just really trying to give them the education and to really address some of the stigma, going over offering family education. I tell folks, bring your family members in here, because what I don't want is my patient going home, and if they decide to disclose to their family members, that everyone starts putting up the dishes, making you wash your laundry separately, and all these sorts of things. So allowing the family members to come on in, let's educate whoever you decide to disclose to, and disclosure is your choice.
Mm-hmm.
So whoever you decide to disclose to, we can do a family or group education. So that makes it a little bit easier. But that all takes time for individuals to really absorb that diagnosis and understand, what I'm saying. I usually do first dose in clinic with me. And so we do rapid start. So a diagnosis, testing, positive diagnosis, rapid start in clinic. And I say, let's take the pill, take the medicine, and that's when I start going through the education. So they spend 20 minutes with me after they've taken their first dose so that they realize, oh, this medication has not harmed me. We kind of go through some of the side effects and whatnot and what the expectation is. And all of my patients know that, I work for them. And if they're not doing well, then I'm not doing my job well. And I take that seriously. Like, I want my patients to be treated like I would want my family members to be treated. We already talked about loneliness and social isolation. This disease is very lonely and very socially isolated, particularly for women. And so really trying to address that, talk about peer groups, peer supports. If your clinic can hire people with lived experience, that's the best. We have a team at our clinic of folks with lived experience. So come on in. So let me introduce you to someone, because hearing from a peer really goes a long way. And it may take a long time for folks to hear from a peer too, particularly women as well. But when that connection happens, that's magical. And if you can get support groups together for groups so that social isolation is minimized, then I think that is really helpful. But the important thing to really let folks know in the beginning is you're going to live a healthy life. My goal is for you to thrive, to reach your fullest potential. What did you want to do with your life before you knew you had this diagnosis? Well, that's what we're reaching for. Okay, because I don't want the diagnosis to be a setback at all in anyone's life. And so really, for me, the importance of trying to get them to that point, but it takes time and it doesn't happen overnight. And sometimes it takes years.
Yes. Fantastic. Ms. Diggs, before I go to the next question, do you have any comments on that? There's a lot. I mean, Dr. Spencer, your patients are lucky to have you. Just very fortunate to have you. You're not doing the 10-minute check-in, check-out.
No,
That's appearing.
they get the time they need.
Ms. Diggs?
Thank you, Dr. Spencer. Thank you. I would say if I was sitting with someone newly diagnosed, as a person who was diagnosed over 20 years ago, the very first thing I would let them know is to breathe, really to breathe. Life isn't over. I've been living with HIV, like I mentioned, for over 2 decades, and I am just living healthy, personally, professionally, spiritually, and I let them know that they can too. I also want them to know that HIV today is manageable, like Dr. Spencer mentioned. And with treatment, you can live a long and full, beautiful life. And once you become undetectable, you cannot transmit HIV to your sexual partners. As I mentioned earlier, with U equals U being powerful, and that it restores so much dignity. But I also want to quickly add one thing about U equals U, that often it gets left out of the conversation that not everyone has reached and are able to reach a undetectable status yet. U equals U was never created to shame or exclude anyone. It's a message of hope and not hierarchy. And the science is very truthful that it empowers people living with HIV, but it also was never meant to make anyone feel less than, or if they're still working towards an undetectable or facing barriers that make adherence a little harder, like mentioned in some of the conversations we've had. Also, I would remind them there's providers like Dr. Spencer who listens, who respects you, who will see you as a whole person, and build a circle within community. Like I am that person who will let my healthcare providers know if you get someone who is newly diagnosed and they need someone to talk to, give them my information. Now, and I won't be the one to call them first. It has to be in their own time. But when they do reach out, if they do reach out, I let them know, most importantly, to give yourself grace. Healing is emotional. As much as healing is emotional, it is physical. And also to let them know that you deserve care, love, joy, and a future filled with possibility. And if you have a community ready to support you every step of the way.
Wonderful, wonderful. As we're heading for the close, I do want to get everybody's perspective on this next topic. We've talked about the changes in the development that's happened with pharmaceutical care, behavioral approaches. We've talked about research as well too. Oftentimes, patients want to have researchers, clinicians, navigators that look like themselves and speak their language as well. How do we get the BDO audience involved in terms of clinical research? And should they? Should they be involved in clinical research?
Of course they should, Dr. King. I mean, that's a given for me. But what we did at ACRA back in the day was we connected our community folks to researchers so that they weren't afraid of the clinician. They weren't afraid for folks to do research. I tell them all the time, people that are, you know, today, if you're diagnosed with a mental illness, and I sit on the National DBSA board, that back in that time, a cocktail consisted of 14 to 18 medications, just like HIV and AIDS. Now, today, you can almost live a comfortable life as a person on the mental health spectrum with one or two medications versus a cocktail of 18 to 20, just like HIV and AIDS. So that's because you participated in those research studies. It's because you went to the table, you sat on community advisory boards, we listened to you, we heard what you said, and we gave you feedback. Our presence was wanted and needed at the table. And all we want is to be at that table when these research decisions are made. And once we're at that table, it gives us a chance to tell you, how is it working for us? How will it work in this community? How will it work with this fraternity or sorority? How can we bridge and get more people to do clinical research? Without this research, we would not be all together today, because we will all be taking more medications that were pretty toxic at the time. And I can't go back to the 80s and blame people for the medicine that they gave because they felt like they were doing the right thing at the right time, but it killed people. AZT was not our friend back in the day. And I remember those harsh days of dealing with that because I'm in the South and I was right down the street from Burroughs Wellcome when they introduced AZT. I did not prescribe it. I saw that it was helping, it wasn't helping our folk, period. So I wouldn't prescribe it. So I knew that once research continued, things would get better. So things get worse sometimes before they get better. But I'm just glad that I was able to see some of the folks that were on AZT back in the 80s still thriving today, because we took steps through research protocols to make sure that we allowed them to see that we were working on their behalf to provide better medications. And that's what this is all about. I tell people, you got to participate in research to get the medications that we need today.
Exactly. Thank you very much. Now we have, wow, I could talk more. I know we can talk more about this, but we only have about 4 minutes left. And I do definitely want to hear each of you. Can you give us a 30-second soundbite of what you want the BDO audience to take away with this on this World's AIDS Day? Let's start with Dr. Tan.
I just want to say that please participate in research. Oftentimes, we are not approached when we are in clinic, when we are seeing our physicians. It is very true, Dr. Spencer, you're a special doctor, because we're often not invited into clinical trials. Because it takes a lot for the physician to understand that what the clinical trial is about. And what I'm talking about is different from what Reverend Gibbs is talking about, which is more community-based. Certainly community-based research studies are easier to access because they actually try to engage community. Many of these clinical trials that are situated in ivory towers are not often accessible, and researchers don't do the necessary engagement. Find out those trials, engage in those trials, and know the IRB at those institutions. The Institutional Review Board at the IRB safeguards your rights as research participants. Know your role, your critical role in research. We cannot advance science without your participation. So, and you have rights and you have ways to advocate for your needs as a research participant.
Fantastic. 30 seconds, Ms. Diggs.
Oh, 30 seconds for me. Really quickly, being healthy with HIV for me means living my life of purpose, joy, and freedom, knowing that HIV does not define me, and that with treatment and U equals U, I'm healthy, I'm whole, and able to love deeply and boldly. One thing I want people to take away is HIV is not the end of your story if you receive a diagnosis. You can live, you can thrive, you can dream, and you deserve compassion, dignity, and community. When we stand together, educate with truth, and lead with love, thriving becomes possible for each and every one of us.
Fantastic. Reverend Gibbs, what do you have for us? 30 seconds.
I agree with everyone.
Oh, lights went off.
I do. I support all of my colleagues here and continue to be on alert with us. And this World AIDS Day is very different because this is the first time that our U.S. government did not provide us with that coverage that said that we could use World AIDS Day from the United States. And this is very sad for us. This is a sad day in America that we can acknowledge the contributions of World AIDS Day to the broader world. But I'm grateful that we're still here to do this work.
Okay. And Dr. Spencer, close with you. We started with you. Let's close with you.
Great. Thank you. And I'm going to put on my provider, research advocate hat and really say, from the beginning, know your status. Really important that everyone get HIV tested, and you may need more than one test. Which was the CDC recommendation, at least one test. You may need repeat testing. And so really important to do that, so that you know your status and you know the status of your sexual partners. Speak up and advocate. It's so important that we get people beyond the choir here to really speak up, educate yourself and speak up. With these federal cuts that are happening to the research grant, to the HIV testing and treatment services, this is going to impact Black and Brown communities much more than the disparities that we already see that exist today. So very important that everyone get educated, everyone speak up. There is something that you can do, even if it's a little thing, writing a letter to your congressman. or your House of Representatives, we have to speak up and do something about what is happening right now, because it's only going to continue to impact Black and Brown communities. Thank you.
Thank you very much. I really appreciate everybody's time today, the passion, the work that you do. It's our community can only get better for what we see here. I want to thank Black Doctors Org for doing this and showcasing everybody here today. Let's continue to create a future where no one is left behind, where zip code does not dictate the type of care that you get. And let's share this video to those who cannot be here today. So everybody enjoy yourselves, be safe, work together, and let's continue doing the work. Thank you, everybody.
Thank you.
Thank you.
Thank you.
Thank you.